All right, hi everyone. So, this lecture is covering advanced skin conditions, including inflammatory skin conditions and sun damage and pigmentation. So, I've already said some of these things in person to you, but basically everything on your test will be in this presentation. If you have any questions about anything, just let me know. So, what is most important in any skin condition is the level of epidermal defense, making sure that that is intact, but especially so for inflammatory conditions. The main job of the skin is to protect our bodies from outside influences. The protective elements of the stratum corneum, that being the acid mantle and the microflora, keep external elements out and keep pathogens at bay because the corneocytes are the first cells of the body that come in contact with the outside world. The stratum corneum was thought to be dead because the corneocytes here lack a nucleus. However, this thought changed when cytokines were discovered. Corneocytes and keratinocytes produce cytokines or growth factors. And cytokines are kind of little messages that alert the immune system of an infection. And the other cell that is an immune cell in the epidermis is the Langerhans cell. Langerhans cells are large and dendritic, meaning they have kind of octopus-like tentacles that are branching extensions that are able to capture antigens. The Langerhans cells themselves are not in the stratum spinosum, like this picture shows. They actually live closer to the dermal epidermal junction, right where the basal layer is. And this makes it so that they're able to work with the dermis and the epidermis. Their dendritic branches can reach up to the stratum corneum. So the Langerhans cells are pretty large. They make up only 2 to 4% of the epidermal cells, but in size, they take up over 25% of the space. And these cells are susceptible to damage like UV rays, chemicals, and trauma. And overexposure to any of these can make Langerhans cells flee into the dermis, causing reduced skin barrier defense systems. So that's because they're not going to be in the epidermis to protect from what I listed earlier, pathogens and bacteria, like they need to be if they're overexposed to any of those things. So the Langerhans cells produce cytokines, and the cytokines that are produced by the corneocytes and the keratinocytes communicate with the Langerhans cells and cause an immune response. And this is called the inflammatory cascade. The immune system also has cells called leukocytes, which are white blood cells, and they send these to the site of inflammation. Then the leukocytes also release cytokines, and these cytokines signal cells to produce self-destruct enzymes called matrix metalloproteinase, MMPs. And the MMPs are chemicals that break down substances like collagen, elastin, and hyaluronic acid, all of which affect our texture, tone, and moisture. Then the leukocytes are white blood cells, and we can see this in action when we extract whiteheads or pimples. Typically there's pus present, which are dead white blood cells fighting off the infection. And continued reactions with inflammation can lead to edema, which is swelling, dehydration, and even hyperpigmentation and premature aging. There are two levels of inflammation. Clinical inflammation, that's visible when you see someone, and subclinical inflammation that's not visible. So subclinical inflammation can cause more damage because we aren't able to see it. So we don't know to stop treatment or to let the skin heal before doing any kind of treatment that can cause inflammation, like peels or microdermabrasion. Typically, though, with some levels of inflammation, there is redness present, even if just a tad, and these are instances where we can also use the cues that we've been discussing this week, like feeling the skin for heat, and then continuing forward with your treatment with that information that you feel. So if someone was presenting with hot skin, I would avoid using hot towels and avoid using steam because there's most likely already activity happening underneath the surface, even if I can't see it, if it's subclinical inflammation. So I don't want to aggravate that. Inflammation causes activation of the immune system. So any type of inflammation will typically produce erythema because the immune cells are being transported to the site of inflammation through the bloodstream. The conditions that we're going to cover are acne, rosacea, different types of dermatitis, and eczema and psoriasis are not covered, but they are considered inflammatory skin conditions. So I just wanted to note that. If you have any questions about those conditions specifically, you can just ask me, but I'm trying to just cover what is on your exam because that's what you need to know, and this is already going to be a long one. But with most of these, there's some level of similarity because they are categorized as inflammatory skin conditions. So the inflammatory cascade is kind of what sets off most of these. With acne, it affects any age group at different stages of life. And as an esthetician, you're probably going to be seeing some sort of acne condition every day. Acne vulgaris is the most common type of acne. Acne affects 80% of teenagers to some degree, which is due to puberty and hormonal changes associated with that. The beginning stage of teenage acne is categorized by minor breakouts in the nose area. And acne affects teenagers because of puberty, meaning there are hormonal changes that are occurring during that time, and an increased production of testosterone mainly. So testosterone stimulates the sebaceous gland, and it can lead to an overproduction of sebum, but it isn't always the cause of acne. You can encounter people with acne that have dry skin as well. But with testosterone specifically, it converts to dihydrotestosterone, which turns the oil gland up, and the elevation of testosterone in the bloodstream begins 8 to 10 days before a woman's period. This is not always that the body is producing more testosterone, but rather there's less estrogen in comparison to the testosterone levels during this stage of the menstrual cycle. And in general, a larger percentage of androgens in the bloodstream increase stimulation of the sebaceous glands. So we have here 5-alpha reductase, which is an enzyme. So a lot of treatments for acne involve 5-alpha reductase inhibitors to stop the conversion of testosterone into dihydrotestosterone. That's typically something that's going to be really helpful for hormonal acne. But in general, acne is also largely hereditary, meaning that if you had acne, if your parents had acne, you may develop it as well. One of the main components that make acne hereditary is called retention hyperkeratosis. Retention hyperkeratosis is a condition in which cells are not desquamated properly. They are retained. So I'm going to break that down a little bit. Desquamation is the natural shedding of the skin cells at the stratum corneum for cell renewal. So if the corneocytes are not being exfoliated, they are being retained, right? And hyper just means more retention. So that means that things like congestion are more likely to happen because of this. And that makes it easier for your pores to get clogged when they're not desquamated properly. The dead cells stick to the surface of the skin and start causing cell buildup within the follicles, which can clog the follicle and lead to things like whiteheads and blackheads and lead to more severe inflammation, like with pustules. And it's not helping the fact that the cells in acneic skin are turned over at a more accelerated rate. So again, hyper meaning more. One possible factor of retention hyperkeratosis is that the skin that experiences this has an inability to produce lamar granules within the stratum granulosum. So if you see here, I know they're small, but the lamar granules exist in the cells in the stratum granulosum, and they're responsible for producing what will become the bilayers of the acid mantle. So the water phases and the oil phases that are composed of things like fatty acids and natural moisturizing factors and amino acids. So all enzymatic activity in your body in general requires water to be able to conduct the processes. The enzyme specifically associated with these cells here in the stratum granulosum are glycosidase and protease. So these enzymes, and this is actually wrong, so just like that. These enzymes break apart desmosomes that cause the skin to shed more easily, aka desquamation. So when the enzymes are not produced, the cells aren't shed. And this is why conditions like dehydration make it more of a possibility that acne will develop if there's already other factors that make acne more prone to developing the skin, which I will cover more of in a second. Another hereditary condition of acne, or factor rather, not condition, is sebum production. Sebum buildup is also genetic, or not sebum buildup, sorry, sebum production is genetic. And sebum buildup becomes sticky and solid when enough cells build up. They form microcomedones. And microcomedones contain dead cell buildup, bacteria, fatty acids, and other cellular debris. And you can't see them because they're deep within a follicle and they can only be seen with a microscope. So technically, these guys are not microcomedones, but you'll sometimes, if you can't feel them on your client, they might feel just a tenderness in certain areas that can be indicative of microcomedone activity. But the main cause of acne is the bacteria proliferation of Cutibacterium acnes. So it's called C. acnes for short, and this is pretty recent. I think within the last 5 years, they changed the name of it. So some other literature still says P. acnes, but it is now C. acnes. So this is the main bacteria that causes acne. And these bacteria are anaerobic, meaning that they can't survive in the presence of oxygen. C. acnes bacteria live on our skin normally. You don't have to have acne to have this bacteria. In fact, you need this bacteria because it's part of the ecosystem of bacteria that survive on the surface of the skin. They have evolved to be able to live in that acidic environment of the acid mantle. And it's totally normal that they do that. That's where they live. That's their home. So a person with acne has it just as a person without acne. The difference between them is that the person without acne does not have clogged follicles that would make the bacteria multiply in a closed follicle lacking oxygen. So they're not going to develop deeper or more severe acne conditions because of that. A blackhead, for example, is exposed to oxygen, which causes it to turn black at the top. Blackheads are open comedones, and closed comedones are not exposed to oxygen, so they develop into inflamed lesions when the clogging in the pore becomes big enough to cause tearing in the follicle wall. And this stimulates the immune system, which releases white blood cells, and what we see on our end is the inflamed lesion. So some types of lesions that we see with acne are papules that are red sore bumps without whiteheads, and sometimes they'll just disappear on their own because the immune system was able to fight off the infection and remove the debris through the cardiovascular system. They affect the nerve ending more than pustules because they're deeper, which can explain why they feel sore. Pustules have transported the infection to the surface of the skin, and they've dilated the follicle opening, so they apply less pressure to the nerve endings in the dermis. And pustules also have a white head. So papules are not something that you need to wait to develop a head to be able to extract them. Just do not extract them in general. If you do, you'll notice that it's not going to be the same as a pustule. Like, there's not going to be white stuff coming out. Most of the time, papules will secrete fluid, like a clear fluid, and it's just going to cause the inflammation to be irritated and cause like more inflammation. So you want to avoid extracting those. Then some more types of lesions are cysts and nodules. Cysts are deeper invasions of the white blood cells, and they're pustular and large, and they must be referred to a derm to remove the cyst sac. So that's what a cyst sac looks like. And sometimes it is surgical. Sometimes people just do it and suture, but you can't do that, obviously. We can't tear the skin open, right? We can only work within the dermis, or the epidermis, sorry. So you have to refer out to derm to be able to handle this correctly. If you try to extract a cyst, it's just going to keep coming back, that pimple, because this needs to be removed. So that's why we don't treat like grade 4 typically. Then nodules are similar to papules, but they're deeper and more solid, and they can feel more sore as well. So there are different grades of acne. Grade 1 is categorized by mostly open and closed comedones with the occasional pimple, and it's the most common grade of acne seen by estheticians. Grade 2 is categorized by a very large number of closed comedones with occasional pustules or papules. Grade 2 is also common to see, and if someone is using comedogenic ingredients, meaning pore clogging, they are probably going to be experiencing grade 2 acne. Grade 3 is categorized by papules and pustules throughout the T-zone and cheeks with open comedones and overall thicker skin. Scarring is likely. And grade 4 is cystic acne because the cysts are deep. Treatment should be done with dermatology or at least approved by a physician. So just because you can't remove the cyst sacs doesn't mean you can't treat the skin at all. Usually inflamed skin with grade 4 needs a lot of barrier repair, so you can always tackle that on that end, and usually that will help with acne anyway, because barrier repair includes the maintenance and controlling of the acne, or not the acne, but the bacteria, the acne bacteria that is in the acid mantle. So there's not like, white tape around treating deeper grades of acne, as long as you're treating it correctly and not extracting things that you shouldn't be extracting. So intrinsic factors of acne include birth control, menopause, pregnancy, and puberty, because all of these have to do with hormones. And stress kind of has to do with hormones as well, which is why I put it here. But I also put stress in external factors. So stress causes the brain to manufacture a hormone that causes the adrenal gland to make more hormones, which triggers an increase in sebum production and inflammation. And that hormone is cortisol. So it's kind of external because things that are outside of your control can be stressing you out, but it is internal in the process that it's hormonal. Then heat and humidity is an external factor because heat causes the skin to swell slightly and humidity causes tremendous swelling to the upper epidermis. Humidity also prevents sebum on the surface of the skin from dissipating as it would in a less humid environment. And sun exposure causes damage to the skin, which causes inflammation. So diet high in saturated fats was not considered to be a factor in acneic skin officially until fairly recently. A question on your test asks, what is not a common cause of acne breakouts? And the answer is foods such as chocolate and pizza. And while chocolate does not typically cause breakouts, but the milk in milk chocolate can, foods like pizza can also cause breakouts usually. And that's just because fast foods or fried foods are usually made with seed oils in their cooking. And seed oils include a high percentage of oleic acid. So that is an omega-9 fatty acid, which is known to cause inflammation, and it also changes the viscosity of sebum. Sebum made with an overabundance of omega-9s in comparison to sebum made with omega-3s and omega-6s causes inflammation because it's thicker and it can clog pores more than normal sebum that everybody produces, which is kind of free flowing and it doesn't cause buildup. So, eating foods that have fats derived from omega 9s can make your sebum thicker, clog the follicle, and lead to acne if you're already experiencing or have other hereditary conditions. And it's kind of like a perfect storm if all of those things are happening at once. So, the test says that these foods don't, but I just want to highlight the importance of diet in acne. And like I said, this is fairly new, like within the last 2 or 3 years. There's actually been studies done that show how those different fatty acids do affect sebum production. So skincare products are also on here because products that are comedogenic can make acne worse. Sometimes it's recommended that severe acneic skin conditions wash their face 2 to 3 times a day to keep sebum levels at bay. But what's more important than that is making sure that you're not drying the skin out too much with harsh ingredients and cleansers because they can damage the pH of the skin. So we need to maintain the pH levels to the 4.5 to 5.5 levels to keep the microflora normal. The next inflammatory skin condition that we're going to cover is rosacea. So rosacea is a vascular condition related to the circulatory system and to the blood vessels. It presents with erythema, sudden redness, accompanied with heat, and telangiectasia, which are dilated capillaries and flushing. And a sudden dilation of the capillaries causes sudden redness. So rosacea is very common. It affects 14 million Americans, and it's ranked as one of the top 5 most diagnosed skin disorders. Rosacea can look like acne, but it's not considered acne, and treatment is very different than how you would treat acneic skin. The rush of the blood can stimulate sebaceous activity and cause red papules and pustules in the nose, cheeks, and chin areas. So similarly to that, so not all rosacea is acne, or rosacea is not acne in general, but they look similar because of the redness. Similarly, not all clients with telangiectasia have rosacea, but most patients with rosacea have telangiectasia. So telangiectasia is what we call broken capillaries, but that's actually incorrect because they're not broken. They are just distended. So broken capillaries are caused by a process called angiogenesis, which kind of makes new blood vessels or capillaries when there is a lack of oxygen happening in the older capillaries. This is also seen on clients with sun damage, and it's seen after injury to the skin, so harsh extractions can lead to this. It can also be more apparent in clients with high blood pressure. So again, not all clients with telangiectasia have rosacea, but almost all people that have rosacea have telangiectasia in some area of their face. Some common rosacea triggers include heat exposure, sun exposure, alcoholic beverages, exercise, saunas, and steam baths, hot beverages, spicy food, citrus, caffeine, and emotional stress. But also, rosacea is largely genetic, and it's more prominent in fair-skinned people and people with Irish or Celtic or Western European descent. Common theory for the cause of rosacea is that the Demodex mite feeds on the oil in the skin and produces heat as a result, which causes inflammation, redness, and itching. Another theory is that there's elevated numbers of C. acnes and Bacillus oleoronus and Staphylococcus epidermidis, and they have been measured in patients, and they do play a role in inflammation. And another common theory is that there is excessive yeast on the skin because one of the drugs to treat rosacea is an anti-yeast medication. But that works because it's anti-inflammatory as well. So it's not necessarily because there is excessive yeast. So that being said, all of these are theories because there is no known cause of rosacea. And there are different ways of controlling it, though, and managing the condition. There's no known cause or cure, but there are things that you can do to help alleviate that. There are 4 types of rosacea. Subtype 1 is erythematotelangiectasia rosacea, and it's the one on the top left. And it's categorized by diffused facial redness, by patchy redness in the nose and the cheeks, and a tendency to turn red very easily. Patients don't have dilated capillaries to be considered for this subtype. Another common thing in this subtype is transient erythema redness, meaning redness that comes and goes, so it's not always presenting red, the skin. It just happens occasionally, probably more so when it's triggered by one of the things on this list. So facial swelling is typical, as well as dry, rough, and tight, grainy texture to the skin that feels like sandpaper with this type of rosacea. Subtype 2 is papulopustular rosacea, and it resembles acne, but there are no clogged pores or comedones present. The pimples themselves are larger than normal, and they're present in the nose and the upper cheeks. And there's redness all over, and sometimes the skin is also dehydrated and has a crinkled look to it. Skin can experience burning and stinging sensations with this subtype. Subtype 3 is called Phimosis rosacea, subtype 3, and it presents as thickened skin, especially on the nose area. This enlargement of the nose is called rhinophemia, and it presents mostly in men, although this type of rosacea is common in both men and women. Then ocular rosacea is subtype 4, and this occurs in the eyes and the eyelids, resulting in eye redness, swollen eyelids, and styes, as well as telangiectasia on the skin in the eyelids. Eyes will typically sting and burn, and you can experience other visual problems as well. So something that affects any type of rosacea is granulomatous rosacea, and this causes hard nodular papules in the cheeks and around the mouth. So it's not specific to any subtype. It can happen with any of these. And another thing that's common is that someone presents with more than one kind of rosacea, even all 4. So knowing which you're working on is important so that you know how to treat it. Most of the treatments for rosacea are medical in that they are prescriptive. So what we can do is make sure to not overstimulate the skin with harsh ingredients. It's best to avoid too much exfoliation, and even a majority of the peels that are made for rosacea, you need to make sure that they're not going to cause an adverse reaction. So just check with the manufacturer if it's not stated that they are safe to use for rosacea. Medical treatments are common. Oral medications like doxycycline is prescribed to manage the inflammation and symptoms. And clients with rosacea should be referred to dermatology for medical intervention when they're not sure what they're presenting with. Like if they have an undiagnosed rash, when blemishes don't fit the traditional mold for acne, or when you just see something that's unusual that you can't recognize. Always make sure that you're referring to derm for things like that because it's a liability on yourself and you don't want to cause damage to anybody's skin. So another inflammatory skin condition is seborrheic dermatitis, and this is chronic inflammation of the oil glands. It's categorized by dry-looking, flaky, crusty patches with underlying redness, and it's common in the T-zone, on the eyebrows, in the hairline, on the scalp, and inside the ears. Causes are unknown, but there is a link to a type of yeast called Pityrosporium ovule, and treatment for this is often steroid creams like hydrocortisone through a dermatologist, and skincare products should be gentle, non-comedogenic, and lightweight. Ingredients like salicylic acid and zinc and selenium sulfide, which is dandruff shampoo, can be used to treat the seborrheic dermatitis. And just like a note here, you can put dandruff shampoo on the face and use it as a cleanser. Not all dandruff shampoos are made equal, but to control this type of yeast, it is very helpful. But if you are interested in knowing what dandruff shampoos are helpful for that, just let me know and I will tell you, because it has to be specific. Another thing you can do to treat the inflammation associated with any type of dermatitis, not just seborrheic dermatitis, is in a pinch, diaper rash cream is made with zinc and it can help calm the inflammation. But usually zinc, sunscreen, SPF, mineral SPF is sufficient in helping with that as well. So over moisturizing these conditions can aggravate the inflammation and cause flare-ups. And fragrance, including essential oils, active products, and drying alcohols, are all going to aggravate the inflammation. And I just want to be clear when I say this that you can still use essential oils for aromatherapy in treatments, but you don't want to put the essential oils on the skin, meaning not even on towels when someone with dermatitis. You want to probably not even use hot towels at all and just focus on calming the skin with like nice cooling ingredients. And perioral dermatitis is dermatitis around the mouth, and it's considered an acne-related disorder. It presents as red papules and pustules around the mouth, the nose, and chin in small clusters. It's often accompanied by scaliness and stinging dehydration. Moisturizers can be tricky with this condition, so it should be non-comedogenic, lightweight, and water-based. Something that can happen with perioral dermatitis is that it's caused by aggravating ingredients in toothpaste. So ingredients like sodium lauryl sulfate are common in toothpaste, and they can sensitize the skin around the mouth. So that's something to look out for, and let your clients know to check their toothpastes if they're experiencing perioral dermatitis. So in dermatology offices, it's treated with oral antibiotic medications, because oral antibiotic topicals, topical antibiotics are not always effective. But again, the zinc will help with this as well, at least with the inflammation. If they have a lot of pustules and papules, refer them to derm. But if it's just some like redness and sensitivity around the mouth, it should be fine. You can try the zinc and just avoid active ingredients and make sure moisturizing is lightweight and all that. So the next portion of this has to do with wound healing. Wounds can be divided into two categories, superficial and deeper, and then into 4 stages. Stage 1 wounds are in the epidermis only and they're superficial. Stage 2 wounds are deeper. A second-degree burn is considered a stage 2 wound, and this is classified as a dermal wound, and we can't perform services on it or treat it. Stage 3 wounds are third-degree burns that extend into the dermal tissue and are classified as subcutaneous injuries. And then stage 4 wounds are the deepest injuries, and they involve bone and muscle exposure. So estheticians can't treat burns themselves, but we can treat the redness and healing issues that come with burns, and with aesthetic issues once the skin has healed. So once the skin has healed, we can treat the residual pigmentation or redness or texture that has resulted from the wound. An example of a wound that we will see often is a compromised epidermal barrier. So wounds are pretty common if we categorize them in that sense. The stages of healing are divided into these 4 stages, but I'm actually going to go into superficial injuries a little bit more before I go into that. So superficial injuries are those where the trauma occurred only in the epidermis, and the healing process starts with re-epithelialization, in which epithelial cells cover a wound. So think back to when you did the first sections of anatomy. We learned about the 4 types of tissue in the body, and the ones that we deal with in the skin are epithelial tissue and connective tissue. And I like showing these kinds of slides because you can really see the distinction between what epithelial tissue looks like and what dermal tissue looks like. It's like a clear line, and also this is most likely a follicle. That's what it looks like, kind of indented here. But we want to start thinking about things in that sense. So re-epithelialization means epithelizing the epithelial tissue. The epidermis is considered epithelial. So what this is a process of covering with epithelial cells once again. So if superficial injuries just kind of like remove the epidermis, re-epithelialization makes sense, right? So within 12 hours of damage to the epidermis, epithelial cells from the wound margin and from the inside of the filosebaceous units begin to migrate to repair the damage, and they're establishing the epidermal cell renewal process to reconstruct the epidermal barrier. The wound needs to be kept moist as it heals because dryness impairs efficient migration of the epithelium. Then deeper wounds, stage 2, 3, and 4 wounds, are all deeper. So the upper papillary layer of the dermis can heal from the injuries without scarring, but the lower reticular layer is damaged. If it's damaged, scars are likely. Deeper wound healing is divided into 3 parts: inflammatory, proliferative, and maturation. The inflammatory phase begins immediately after injury, and this phase is called vasoconstriction. So that means the narrowing of blood vessels by small muscles in their walls. And this establishes hemostasis, which is the control of bleeding, followed by a couple of days of vasodilation that allows a buildup of necessary cells and protein to repair deeper wounds. During this phase, fibroblasts are stimulated to regulate the production of collagen. The next phase is the proliferative phase. And this typically begins about a week after injury or incision. The wound has increased blood flow now, and it's critical that nutrients and oxygen are provided to sustain the metabolism of the healing wound, namely the deposit of collagen. So closing the wound with sutures, with staples, and butterfly stitches or special adhesive help to minimize the granulation tissue and accelerate wound healing. And this is healing by primary intention. The natural healing process of wound healing without any assistance, just what your body normally does without you having to do anything, is called healing by secondary intention. Wounds that heal with primary intention have a decrease in wound size by up to 40%. So depending on the depth of the wound, primary intention healing is, of course, more beneficial. The maturation phase is the last stage of wound healing, and it's categorized by an increase in strength without increase in collagen content. So during week 3 and 6, the maximum amount of collagen was laid down in the wound, and the collagen is then remolded and realigned to the maximum wound tensile strength. So enzymes that we discussed earlier the MMPs that are present in the inflammatory cascade. They're the ones that kind of eat away at the collagen that's been damaged and make sure that sufficient collagen is in the area to allow for wound healing. So, a month after injury, the strength of the tissue will be increased to about 40% of the pre injury strength, and it peaks at 80%. So, it's not always going back to how it was, but 80% is pretty good if you consider the level of damage that was done, typically with grade 4 wounds. So now we're going to move on to pigmentation, and this does get a little complicated just because the enzymes and amino acids that we're going to be describing sound very similar. So I'm going to do my best to enunciate as clearly as I can, but because I'm talking a lot and I don't have any water, I forgot it in class, I feel like I'm developing like a lisp or just not saying things clearly. So I'm gonna try my best, but if I sound crazy, that's why. So, short-term sun damage is basically a sunburn, and within a few days of a sunburn, the redness will disappear and the skin will tan, depending on the melanocyte activity that protects the skin. The first few days after excess sun exposure, the skin is working overtime to try and repair itself during the inflammatory cascade. So keep in mind that even if your skin doesn't look like it's damaged after your skin heals from the sunburn, there's always lingering molecular damage after a sunburn. So the UVR spectrum penetrates from 200 nanometers to 400 nanometers. UVB penetrates the epidermis and it's responsible for most epidermal cellular damage, and it can create erythema and sunburn, and this re-stimulates the melanocyte to trigger melanogenesis. UVA penetrates the skin to a greater depth than UVB, and it's classified into two divisions, UVA1 and UVA2. And this UVA ray penetrates into the dermal layer and it increases the MMP enzymes, collagenase, that occur with UVA exposure. So that is why sun exposure that penetrates into the dermis results in an aging appearance, because the enzyme, the same enzyme that we were just talking about, the MMP enzyme, specifically collagenase in this sense, is kind of like removing the dead collagen. So if you are not protecting your skin with sunscreen, that is going to super age your skin. It's going to result in kind of like a deterioration of the foundation of your skin, the dermis. So UVR can increase free radicals, it oxidizes pheomelanin, and it damages dermal proteins by increasing the MMP collagenase and elastase. And it oxidizes vitamin C, it neutralizes vitamin A receptors that already live in your cells, and it damages the DNA. So it is a very serious thing. And that is why sunscreen is so important. Of course, we do need sun exposure for vitamin D, but 15 minutes is sufficient in your vitamin D levels. So you don't have to be in the sun, for more than 15 minutes without sunscreen to synthesize vitamin D. So now going into melanogenesis. This is the part where I said it might be a little tricky, but everything is on the screen here. So I'm just going to point to what I mean as well as say it so it's very clear. So in the basal layer, the melanocyte forms melanin, and melanocytes are dendritic, like nerve cells and like Langerhans cells. So just because it lives in the basal layer doesn't mean it's only reaching the cells in the basal layer, right? And it's also depositing melanin into the cells that are above the basal layer. So for one keratinocyte, there's 30 to 36, for one melanocyte, there's 30 to 36 keratinocytes. So that means that one melanocyte is supplying numerous cells with the same pigmentation pattern. 1 in every 10 cells in the epidermis is a melanocyte. So we want to make sure that this pigmentation pattern that the melanocyte is distributing to the other cells is what we want, right? If there is damage to the melanocyte and it is distributing excess melanin, that's going to result in pigmentation. So melanin is the pigmentation granule, and it's partially responsible for the color of skin. There are two pigments of melanin. So we have here pheomelanin and eumelanin. And the production of the melanin is called melanogenesis, and it's part of the skin barrier defense. Melanin production is entirely dependent on UVR exposure, and UVR exposure sets off the chain reaction that is really a response to UVR damage. So eumelanin can absorb the energy of all of the visible UV light without it becoming a free radical. When light enters our skin, it is either absorbed or neutralized by melanin to prevent damage and the production of free radicals. So this is why people think that darker skin types don't need sunscreen, because we have eumelanin, so it's not becoming a free radical. But UVA exposure is still going to damage the dermal tissue, even if melanocyte activity is not produced. And in fact, excess melanocyte activity can still happen, which is what I'm about to get into, and that can cause the pigmentation to still occur in deeper Fitzpatrick types. So, melanin production is stimulated by UV exposure, and it begins by a protein called propionmelanocortin. And that is stimulated by the pituitary gland, and it's a precursor to the melanin stimulating hormone. The enzyme tyrosinase, so tyrosinase up here, this enzyme plays a key role in melanin synthesis, as it's a catalyst to the amino acid tyrosine and the formation of a pre-melanosome within the melanocyte. Within the melanosome, pigment granules of melanin are synthesized from the amino acid tyrosine through the actions of the enzyme tyrosinase and the metabolite L-DOPA and dopaquinone, which both regulate and are building blocks for melanin production. So this is how tyrosinase inhibitors work. They inhibit the enzyme tyrosinase, and if you can block the tyrosinase, you can reduce the formation of the pigmentation granules, melanin, and it can lighten the skin. So this picture might make it seem more confusing, but this is kind of just the chain reaction that happens through the UVR damage. Hyperpigmentation literally means overpigmented. Liver spots are a type of hyperpigmentation, and they're directly related to overexposure to the sun. Hyperpigmentation can suddenly appear and show years of unprotected sun exposure when it does. So using a Woods lamp is helpful to identify pigmented skin that you don't always see with just normal sunlight. Melasma is a type of pigmentation disorder, and it's caused by an imbalance of hormones affecting melanin production, and it's made worse by sun exposure. It occurs mainly in women, and it is treated with a combination of topical treatments and sometimes a topical steroid. Physicians can also analyze the hormonal blood profiles of a client and make sure that their recommendations are suited for them specifically, or they can make recommendations for hormonal therapy or birth control based on that profile. Clients with melasma have to wear broad-spectrum sunscreen during daylight hours, and treating melasma requires a lot of diligence and commitment from both the client and the esthetician. Tinea versicolor is what many refer to as sunspots or sun fungus. They're white spotches, and they don't actually always have to be white. They can be brown as well. That's why it's called versicolor. There's versatility. But typically they are white, and they appear on the chest and the back of people who love to sunbathe. They're constantly in the sun. and they are actually a fungal infection. The fungus interferes with the melanocyte's ability to make melanin, and it makes the white splotches appear when the body is tanned. So you might not always be able to see them if the body is not tanned, but once you get a tan, you typically see the resulting splotches. So this needs to be referred to a derm to treat the fungal infection. So sun exposure actually suppresses the immune function of the skin. The sunlight chases off the macrophage cells and Langerhans cells and allow for substances and organisms to enter the skin, which increase the change of infection. With repeated sun exposure over the years, collagen and elastin fibers in the dermis begin cross-linking or collapsing because of the effects of cell damage, which cause the support system of the skin to collapse. What we see with this is deep wrinkling and sagging. So, dermatoheliosis is the medical term to describe long-term sun damage. So, some disorders of the skin that are not related to pigmentation in specific, but we still need to cover, are sebaceous hyperplasia. Sebaceous hyperplasia it looks like a small donut-shaped lesion that looks like a large open comedone surrounded by a ridge of skin, but when you try to extract it, nothing's going to come out. And that is because these are actually overgrown oil glands that are found on people with repeated sun exposure. I actually have some if you want me to show you. Usually with on people 25 and older. And these are types of benign lesions, and they can be removed with electrodesiccation with an electric needle, a laser, or sometimes chirosurgery. Actinic keratoses are rough areas of sun-damaged skin, and they're indicated by dysplastic cell growth. So that means that they're related to abnormal growths. They're found on people who have had chronic sun exposure, and they're prevalent in lighter Fitzpatrick types. They are red and pigmented rough patches that can be crusty, scaly, and rough to the touch. They can occur anywhere on the body, but they're frequently found on the temples, the forehead, the hairline, the ears, and the hands. And they can become cancerous, though sometimes they are benign as well, but they have to be watched carefully because of this. So sometimes they're referred to as precancers, but if you see someone that has actinic keratosis, just ask if they have seen a dermatologist, not in like a scary way that makes them freak out, but just, as a general intake thing. And then sebaceous seborrheic keratosis, These are called SKs for short. Seborrheic keratoses are large, flat, crusty looking brown, black, yellowish, gray, or sometimes even flesh-colored lesions that are often found on the face of sun-damaged skin. They look like a scab, and clients will sometimes pick at them, which will hurt. So you don't want to pick at them like that, but they're pretty harmless and they are benign. So dermatologists can remove them with freezing therapy or by chopping them off. Usually, same thing, you want to keep an eye on them, but because they can occasionally turn into something much more serious, like basal cell carcinomas. But most of the time, again, just make sure that everybody is good on their skin checkups. So knowing a dermatologist is really helpful for this so that you can have someone to refer clients to. But oftentimes people are not going to derm for sun check-ins or spot checks every year. So them seeing you every month is much more likely than them going to derm that often, So we are sometimes the point of contact for people for things like this, but we honestly cannot treat these conditions. Now we're going to go into skin cancer. And skin cancer is caused by cells dividing unevenly and rapidly, while the genetic material in the cell's DNA is damaged and altered because of cumulative sun exposure. When first exposed to UV light, the melanocyte responds by sending melanin to the surrounding cells. Then the melanin situates itself between the cell nucleus and the source of the UV light in an effort to protect it from sun strikes and damage. So, the first type of skin cancer is called basal cell carcinomas, and this is the most common kind of skin cancer. They're almost always found on sun-exposed areas like the face, hands, legs, back, and chest, and they look like small pearls or waxy-looking nodules. They can sometimes have a small vessel running through them as well. On older skin, they can be harder to differentiate than milia, but usually they are pretty clear. And in the early stages, they can look like red patches on the skin, which causes clients to treat them with moisturizers because the flakiness looks like dry skin. Basal cell carcinomas are curable most of the time. In fact, 95% of these cancers are cured, and there's 99% survival rate after 5 years. So they are rarely spread to the internal parts of the body, but they can grow, and if they're not treated, they can affect larger areas of the skin and cause large scars when they're removed. Squamous cell carcinomas are the second most frequently diagnosed form of skin cancer, and they look like red or pink solid bumps on the skin. They can also appear as open sores or ulcers that don't seem to heal. They can look crusty, but they don't have to, and the crusty area, if it is crusty, can sometimes bleed. A lot of clients notice that this happens when they're washing or cleansing their face. So these lesions appear on chronically sun-exposed areas, and treatment is similar to treatment for basal cell carcinomas. But squamous cell carcinomas may sometimes spread to other areas of the face. In Mohs surgery, which is a specialized surgical technique that's named after Frederick Mohs, MD, the dermatologist trims more and more tissue from the cancerous lesion, carefully checking each sample of tissue for any cancerous cells under a microscope until all of the tissue is removed. Then the final kind of skin cancer is melanoma. This is less frequently seen on people, but it is the most deadly. Melanoma originates in the melanocytes, so it can affect any part of the area that has melanocytes, and this includes the intestines, the eyes, the brain, the spinal cord, and other tissues. It's the most aggressive kind of cancer because it quickly metastasizes to the lymph nodes. So melanoma in the skin is the most noticeable form of melanoma because we can see these kinds of markers for it. But the other kinds are not as easily observed, the ones on the skin. Melanoma is categorized by moles or mole-like lesions that change shape and color and grow asymmetrically. They have uneven borders and are obviously changing in appearance. So that means, I'm not saying obviously, I'm saying like over time, they have obviously like very apparently changed in appearance. So they can appear anywhere on the body, including the scalp and even under the nails. Melanoma is the kind of skin cancer that affects the greatest number of youth, being 25 to 29 people, like that age range. And there is approximately like 70,000 cases as of when I wrote this, so that may have increased. But people die yearly of the disease, so it is very serious, and it's important for us as estheticians and people that look at the skin often to see and check for signs of melanoma on the areas that we work. To recognize it, we have the ABCDEs of melanoma. A stands for asymmetrical, so the melanoma lesion is usually growing to one side of the lesion and it's uneven. B stands for border. So that means that the borders of the melanoma are uneven and not smooth. C stands for color. Melanomas are dark brown or black, and they're usually splotchy or not of just one color. D stands for diameter. Melanomas are usually at least the size of a pencil eraser or larger. Regular moles are typically smaller than this. And E stands for evolving moles. So changes can include darkening